All right, good afternoon, everyone. Thank you for staying for the end of the meeting and for coming to what's going to be the fourth Dragon's Den and Burst session. I'm stepping down as trainee rep of the section of academic urology, and Viru is taking over from me. So thank you for coming and joining in with our activities over the last couple of years. It's been a privilege to be involved, and I hope to stay involved in the future. We'll start off with an update of the Burst Trainee Research Collaborative with reports from each of the committee members briefly highlighting what we've been doing over the last year. And then we'll have our fourth Dragon's Den. We have an esteemed panel as ever with Professor Emberton, Ian Pearce and Graham McLennan to take on our presenters and hopefully give some constructive feedback. This year there's an app with the opportunity to ask questions via the app rather than sticking your hand up the old-fashioned way. If you go to Hall 3B, if you click on the Ask a Question icon on the app, if you've downloaded it, you can type in your question, Hall 3B, and then the panel will be able to see your question and read it out for you. Safe putting your hand up. So I'm going to hand over to Viru to just update us all on the Burst Trainee Collaborative and tell us what's been going on.
Thanks, Ben. So I'm just going to give you an update about what's been happening over the last year or so. So my name's Viru Kasivisvanathan, I'm the chair of the Burst Research Collaborative. So what does BURST stand for? It stands for British Urology Researchers in Surgical Training, and we form a network of urological registrars and academic urological consultants who are interested in producing high-quality collaborative research and audit. Our vision is to support and encourage trainees to take part in collaborative projects at their own units, and it's a way of trainees gaining research skills necessary for CCT, and a way of future-proofing trainees and the specialty. And I want trainees to go from consumers to producers of research. So I'll go through a few of the highlights of the year. My committee will also tell you some specifics. So we formed a committee. That's the first thing we did. We were successful in obtaining funding. We had a submission to an NIHR HTA grant. We contributed to a national consensus guideline panels on CCT guidelines for research, which is, I understand, is actually changing practice. And we're launching MIMIC. So MIMIC is a national trainee-led study, and I'll just tell you one or two things about that now because you can get involved in this study right now. So MIMIC is a multi-center cohort study of patients who have presented with acute renal colic and CT-KUB evidence of a solitary ureteric stone. So if you want to contribute to a national study and be recognized in the paper, this is your opportunity. So there is conflicting evidence in the role of inflammatory markers in the likelihood of intervention in these patients. And our research question is there an association between white blood cell count and time to intervention in patients who present with acute ureteric colic? Our primary outcome is time to intervention from presentation up till 6 months. So we've completed the pilot study at 6 UK centres and 120 patients, and the full phase, as of now, is open. We're looking for 1,000 patients from at least 20 centres, and we expect trainees to submit data for 50 patients, which takes about a weekend of work from our pilot study. And there are some flyers which are scattered around the room, which you can have a look at, which give you more details on how to get involved. If you're interested, please email Tamer, who's here today, on tamer.shah@doctors.org.uk, and he will set you up with the necessary things to run the study at your site. I will now hand over to Tamer for the webmaster update.
Thanks, Viru. Good afternoon. So my name is Tamer. I am part of the Burst committee and also designed and run the website. And this is a very quick update on the website itself. Some of you may have already seen it. It's relatively straightforward. Our front page includes our Twitter feed. It also includes any current projects that we may have running and you can also access it via our menu bar. So current opportunities, self-explanatory, shows what's available for us at the moment. Projects, very similar. It's got a little publications page, which at the moment is pretty bare, but hopefully we'll build this up over time. And it also shows you how you can submit an idea to us as well. In terms of statistics, that graph didn't come out at all, but it's our birthday today. We're 1 year old. The website's been up and running exactly 365 days. And in that time, we've had 6,000 hits, which is pretty good. And we're averaging about 500 hits a month. On top of that, it's not just the UK. We're getting basically worldwide appeal. We've got over 1,000 hits from the US and have hits from places such as India and Israel. And if you search us on Google, we should be one of the first searches, which is partly from the website, but is also from Sophia's work with Twitter, which I suspect has really boosted this on Google for us. So that's my brief update on the website. You've probably got the name already, but if you haven't, it's up there. And our email address is up there as well if you've got any questions or if you want to get involved. Thank you.
So, Marcus, do you want to give a quick update? Finances?
So, afternoon everybody. Thanks for the opportunity. My name is Marcus Cumberbatch, an academic trainee from Sheffield, and as you may have guessed by the picture, I'm the man in control of the money, and I've been elected as Treasurer of BAUS16. So, just going to give you a bit of an overview of the cash flow for BAUS16 so far, the ins and outs, where we're looking to apply for funding here on in. The first job I had sort of in December time was to try and get a bank account, so we now have a NatWest Community Charities account, and we were able to immediately deposit around £5,000 thanks to our sponsors, BAUS, BJUI and the Urology Foundation. In the last 6 months, we've spent about half of that in trying to develop the online presence that Tamer just mentioned, and also trying to bolster our index project Mimic through some additional statistical support. So the real challenge for me was to try and see if I could recruit more funds. So this has been through scattergun approach through emails, but also face-to-face conversations with both fund-giving bodies and industry. And I've had sort of conversations with people like Coloplast, Janssen, and the Urology Foundation to try and achieve mutually advantageous routes forward. It's been a challenge. Being a treasurer is quite a new thing for me, except for when I was the treasurer of the UCL football team. So it's becoming an increasingly educational process. But I think what we can say is that we're going to try and formalise our strategy going forwards, submit applications for sort of small project grants, try and form some specific statistical help requests, and also try and develop arms in other areas rather than sort of disease management and epidemiology, and also looking at sort of technology innovation and also developing our teaching arms. So I think for me, the main sort of summary for today is to see if I can get some input and help from the audience as to ways to go forwards, and also we'll discuss, I think, a bit more in our AGM afterwards. Thanks.
That stage is too tall for me. I'm Sophia, I'm the secretary. This is going to be really quick, but basically just a bit of an overview on our structure. So we try and meet 4 times a year at least. Originally, when I heard of BAUS16, I was a bit worried that it was all academic and all London-centric, and just to make it clear, that's absolutely not the case. I've got 0 academic background. I did need to tick the box on my ARCP, so I'm doing something academic, and actually this is a really brilliant way of getting anyone, even with the most limited understanding of research, into urological research. We're very open, and everyone's welcome to join in, even if you're just kind of co-opted into one arm of one of the studies. We tend to meet 4 times a year. We Skype twice and then meet here at the BAUS meeting and then at the winter academic meeting. We also are aiming, it's not in process as yet, but to send out quarterly newsletters, and there will be one after BAUS. And we do have a mailing list. If anyone does want to be on it, just let me know. I can add you to it. We've got quite a few people on it already. Even if you just scan it and bin it, at least you know what's going on. Also, we are trying to boost our Twitter presence. we've got over 200 followers at the moment. To start with, we were a bit rubbish. We had about 100 impressions a month, which is rubbish. But now we're over 3,000 a month, which is pretty good. We tend to peak around Burst, around BAUS even, and around our December meetings. We got about 5,000 impressions in the last meeting in December, which is good. And our followers are fairly well spread. We managed to get someone in Brazil, I don't know how. And that's about it, really. But if you do want to get involved, then following on Twitter is really easy, because, again, you can skim it, and if you're not interested, you can just skip past it. And if you tweet us, we'll follow and DM you back if you need anything. Yeah, and that's our Twitter handles, @BurstUrology, and then the website and the email if you want to go on the mailing list.
Hi everyone, so my name's Arjun Nambiar. I'm a trainee in the Northeast and I'm the education lead for Burst. And following on from what Sophia said, just to show that Burst is not a London-centric organisation, we've got a Northeast presence as well. And education is something that I think is going to be one of the core remits of Burst, because it's a good way for trainees. I've spoken to a number of trainees and they all say that we have very little knowledge of clinical statistics. We have very little knowledge of research methodology in general. And everybody recognizes that's something that we need to promote, and having access to education is very important to trainees. But the question of how we deliver that is something that we need to think about, and we need to, as a group, and you guys as well, if you give us some feedback on how you think would be best to deliver that type of material, that would be good. What we've got so far, we've already started this in London. Veeru's had a discussion with the guys in London. I'm trying to do it in the Northeast, is to set up regional education as part of the regional teaching program. And if we could get somebody from every deanery in every region to be a contact, and to try and streamline that, and to try and systematically deliver that everywhere. One day a year is not asking much. Every region has a teaching program, so it would be great if we could deliver that to every region in a systematic fashion. Of course, we also have the Burst course at BAUS, which is going to be held tomorrow. Yeah, tomorrow. So that's something that people can get involved in. Again, the feedback from that is something that we'll have to see tomorrow. See if that's something that's feasible to take forward, and that's something that has a lot of interest, then certainly we will. And of course, there are teaching programs, there are research teaching programs everywhere happening very frequently. These are some of the ones that we personally would recommend as good ones to take part in if you're interested. But that is very much a self-led thing that you need to look up online. But if you need any information on that, we're always happy to help as well. So if you are at the course tomorrow, you're welcome to join. I think there's still places available. So if you are interested, please go down to the registration desk and join up. And if you have any feedback or any ideas, let me know. And watch this space. We'll keep you updated. Thank you.
Thank you, guys, and thank you also for your hard work over the last year. So if I can invite the dragons up to the table. So the format of the session now is the exciting part. So 3 people are going to present their ideas which were selected for presentation. And after the presentation, which will last around 8 minutes, we'll then have about 5 minutes for questions. And questions will be starting from the dragons, and they can go on to the audience. So you can ask these guys some questions to make them feel a bit uncomfortable as well. If I could invite the first speaker, Riyad Chebu, who is a medical student from Sheffield. We have people interested in Burst who are medical students too. So we won't give you too hard a time.
Thank you very much. Cheers. So yeah, my name is Riyad Chebu. I'm a medical student from Sheffield, and I'm here presenting on behalf of Burst a research study entitled Orchidopexy for Testicular Torsion, a systematic review of surgical technique. So I'll start off by briefly going through the study rationale. So testicular torsion is a common neurological and pediatric emergency. It can lead to permanent ischemic injury of the involved testes. Management often includes orchidopexy, and there's variation reported in the surgical technique of orchidopexy in the literature. This includes the type of suture used, the fixation methods, any synchronous procedures used, and whether the contralateral testicle should be fixed. The European Association of Urologists guidelines state there's no common recommendation about the preferred type of fixation and suture material. A regional survey of practice conducted in 2002 by Pierce et al. Indicated there were substantial variations in policies for the management of suspected testicular torsion. As such, it's been discussed in urological circles for many years, and current reviews and evidence of the operative management are heterogeneous, dated, and few. This is our rationale for the study. And what we propose is a research model that consists of three parts or three studies. So firstly, to start off with, is the review. So really to describe, summarize, and analyze the literature thus far, and look at the reported surgical techniques and what their outcomes are following orchidopexy for torsion. Secondly, to conduct a national survey of practice. So essentially a snapshot of current torsion practice across the UK by consultants and trainees, looking at management in general, but also asking about surgical technique. And then finally, to have a consensus meeting, have that led by urology trainees, looking at developing guidelines and recommendations on the management of testicular torsion based on the survey, the review, and the rest of the literature. So I'll talk about how trainees can get involved. So the review, for a start, needs authors and people that can conduct the search strategy. So that's perfect for trainees to get involved. Secondly, in terms of the survey, responding to the survey so we have that data. And lastly, the plan is to have trainees leading, organising and attending the consensus meeting, leading to subsequent collaborator authorship. So really to get trainees involved as much as possible. So I'll focus on the systematic review and then come back to summarise the whole research model at the end. So really the question we're asking with this review is whether those that have testicular torsion and undergo orchidopexy, what are the techniques used and what are their subsequent outcomes? And the outcomes we're looking at primarily is the recurrence rate of the ipsilateral testicle, so the one that's twisted and then fixed. Also to look at the outcome in terms of atrophy for that testicle, and also to look at recurrence rate and atrophy for the contralateral testicle, so the one that isn't twisted but may or may not be fixed, and to look at fertility outcomes following orchidopexy. And then looking at those outcomes, then do a subgroup analysis looking at different techniques used. So that could be the type of suture, the points of fixation, synchronous procedures, and whether there's contralateral fixation. It's a broad inclusion criteria from case reports, observational studies, and interventional studies. Just looking at orchidopexy for acute testicular torsion, and those that are reporting surgical technique at least being able to answer one of the outcomes. So then excluding non-English language studies that are looking at torsion in neonates, so we only want adult and pediatric population, reviews, comments, editorials, abstracts, and conference proceedings, and those studies looking at orchidopexy indicated for undescended testes or intermittent torsion. So our strategy really is initially to have a broad search, so around 2,200 studies. Then to have 4 authors split into 2 pairs who can then go through the titles and abstracts of these studies, and then to have a 5th author who can resolve any conflicts. We'll be using Covenants, which is quite a neat online website for conducting systematic reviews. This is just a snapshot of one of the pages of it. Essentially, you can upload your studies from PubMed straight onto the website. You can set your rules on what authors can do, and all authors can log in. And then from that, you can go through each of the titles and abstracts and quickly review them. And you can do it on your phone, have the inclusion-exclusion criteria at the top of your phone, and literally just peruse through the titles and abstracts and be able to quickly go through them. And this is a great way of getting trainees involved across the country to be able to interactively do the review and be able to calculate conflicts which can be resolved. So, taking a step back, the National Survey of Practice will be a UK-wide online survey using a platform like SurveyMonkey. Questions which will pertain to overall testicular torsion practice to really gain that snapshot, and looking at responses from trainees and consultants. And again, emphasising that this consensus meeting will have to be trainee-led. Trainees are organising and leading the meeting. We're looking at using a Delphi consensus methodology that involves a series of rounds, starting with an open-ended questionnaire where you can gather trainee and consultant opinions on technique of surgery and testicular torsion management. This can then be synthesised and ranked, and from there you can have a meeting and come to guidelines and consensus. And at that meeting, we really want to have regional UK representation, so a trainee and consultant from each region to really make it a UK consensus. So in summary, the research package offered is starting with a systematic review, a national survey and a consensus meeting, and throughout to have for it to be trainee-led and trainees involved and to be able to get authorship through work in this study. Another key theme is to have national representation, so trainees and consultants from throughout the UK. Thank you for listening.
Thank you, Riyadh. So if we could start with Ian.
Yeah. Thank you very much. Very enjoyable and fabulous quoting of the literature, which means I'm not really sure if I have any questions apart from to say it's fabulous. I'm just slightly confused. When you say you talk about atrophy, it's purely literature search, is it? There's nobody, you're not actually recruiting anybody?
No. In terms of atrophy, so either defined clinically or by ultrasound, and that's just in the studies. So some of the studies you find, they do report that.
Yeah. Yeah. And do you have a feel from your literature searches how many studies have actually looked at atrophy?
Yeah, we did an initial, more refined search that started off with just about 200 abstracts and titles, and from that we've managed to gauge what sort of data is out there and what outcomes we can report on. And atrophy was reported in some studies, so we feel that is something we could at least qualitatively, if not quantitatively, summarise.
And this is just sort of a question really not related to your protocol, which I think is very good. But do you think there is any variation depending upon the age at presentation of the patient? So, for example, if you're 47, for example, and have a torsion, I'd wager it's not quite such a big deal as if you're a 16 or 17-year-old boy.
Yeah. Yeah, I agree. I think there will be differences in outcomes and the impact of them. I think it would be interesting to see what sort of studies we get and what those age groups are, and that might be a demographic we look at and see whether there's different results in those different age groups.
Okay, thanks.
Thank you.
Great. Well, congratulations. I think it's always refreshing to see somebody shedding some light into very dark corners of the urological experience. And it is interesting that one of the most common exam questions, and this is one of the most common exam questions, has almost no evidence base to support the answers. So it's quite interesting. So my first kind of comment would be on scope. I think it's going to be very hard to study torsion, but it might be easier to study emergency scrotal exploration. In that that's what we do, and there are several outcomes to that, one of which, probably one of the least common ones, is actual torsion. And we do stuff to the scrotum even if we don't find torsion. So it may be that coming back a little bit from the question, and actually if what you're scrutinising is the surgical intervention, then broadening that a bit to embrace all the things we do when we're worried about torsion. But actually torsion is the least likely outcome, usually.
Okay, yeah.
And that might be an easier way to search, and actually might be more meaningful in that what we do to the testis and the other side of the testis when we don't find torsion, or when the diagnosis is unclear and you think there may have been torsion, may be as interesting as when the diagnosis is absolutely clear.
Yeah, I think that will certainly bring a broader amount of studies, yeah.
And I suppose my other comment would be, you're ignoring the area where there is a lot of literature, which is in the kind of diagnostic process. So in other words, the bits that lead up to that boys or adolescents or young man's admission and the decision to operate, and the utility of ultrasound, clinical examination, etc., in changing your prior probabilities about whether to undertake the emergency exploration of the scrotum, and whether if you deliberately excluded that, and if you have, whether you think that's subject to a different study.
I think that's, like I said, possibly subject to a different study and would make maybe the goals of the review quite broad. I think that certainly there is literature there already reviewing and summarising that data. So maybe that's something that comes into sort of the discussion of the review and how that needs to be looked at. But I'm not sure whether in the conduct of the review it might lose a bit of focus if we then bring those factors in.
I think I agree with you. I think it would. But it might be quite nice to deliberately say that you've excluded that. One of the most important things about systematic review is the scope. So to define in advance what it is that you're going to review. Otherwise you get halfway through it and you find that actually you're all over the place. So I think precision and scope is going to be really important.
Yeah. Thank you.
Thanks for that pitch. As ever, I've got my hat on as if you were asking me for money to do this. And the first question I would ask you if you were asking me for money to do this is, why aren't there any patients involved in this?
In terms of doing a study
in
involved...
terms of the whole thing, you've got a consensus, well, your consensus process, you're collecting outcomes. And I'm assuming you're measuring the outcomes that are important to surgeons, but I didn't see anything up there about the outcomes that were important to patients. How are you going to establish that? Do you know that already? I'm being aggressive just as an act, I don't...
I guess by looking at the fertility outcomes, that may well be one of the important factors for patients. As far as I know, I don't think there is data looking at patient opinions and patient thoughts and outcomes afterwards. That would maybe require a survey of patients. That's not included, but it's a very good point. Yeah.
Speaking of the survey, how are you going to get hold of the addresses of the people that you're going to survey?
The trainees and consultants. I'm not quite sure with that myself. I think that would have to be something discussed within BAUS16, and I'm sure there'd be a method through an association or organisation to get emails of trainees and consultants nationwide.
Do you think you need ethical permission to approach people?
Yes, I think you need university ethical permission to conduct a survey.
Well, as a tip, if you get their addresses from a professional society, that the consent for them to take part in the research is implied by the professional society granting you access to them. So that would be something you don't have to worry about if you get them through, say, BAUS, for example.
Okay. Yeah.
Can I just press you on the first question? So how much money do you need to do this study? How much are you asking for?
So, in terms of money needed, Covidence has actually, because I've already registered the survey, the review, it's actually free of charge. SurveyMonkey would need a bit of money. But
running consensus meetings costs, you have to rent a room, people have to travel, it's people's time.
Oh, yes, the consensus meeting would need money as well, yes, indeed.
Do you have a figure in your head that you would like to share with us?
I'll go ambitious, possibly around the ball figure of £500.
Ooh, that's a lot.
Sorry, can I ask another question? If you're surveying consultants and trainees, at what level of training would you expect somebody to have all of the answers to that, to your survey? Does the ISCP logbook or the curriculum, when would you be expecting somebody to be completely competent and have a thorough knowledge of what they would use and what else they would do at the same time?
I myself would be unsure on that. I mean, safely you could go for senior registrars and above. I think that's definitely something that would need considering because I think you quite possibly have different answers from people with different levels of experience. So I think that is something we need to consider. And
would you stratify the results from the survey then? Is that what
we
do?
We could, if we kept it open to all trainees, then we could quite easily stratify the results by asking people what their level of training is and maybe asking people how many orchidopexies they've conducted. Or we could set a cut-off at a level of which we feel is appropriate.
Okay. The other thing I'd just ask is, I just wonder how many consultants have done an orchidopexy for torsion in the last 5 years? Oh, perhaps it's just me. I sleep easy, obviously.
Thank you.
Okay, thank you, Riyad. I'm sure you'll agree he presented well and did very well. So round of applause for him.
Thank you.
So, we've got a very interesting presentation now, which is going to be given by Ben Lamb on behalf of another trainee who couldn't make it today. And the title is Just Add Water. Can irrigation with sterile water post-TURBT reduce recurrence of bladder cancer? And over to you, Ben.
Thanks. Good afternoon, everyone. I'm presenting on behalf of Max Johnson, who's a core trainee from Winchester, who unfortunately hasn't been able to come today. So I'm Ben Lamb. I'm a urology registrar at UCLH in the Department of Urology, and our senior author is James Green, who's a consultant at BAUS Health. So non-muscle invasive bladder cancer is a common and ultimately quite expensive disease for patients and healthcare organisations. It's reputedly the most expensive of cancers to look after because of its recurrent nature and chronicity. The standard of care for non-muscle invasive bladder cancer at initial resection is to use a 40 milligram dose of intrathecal chemotherapy, mitomycin C. This has been shown in a number of studies, systematic reviews and meta-analyses to give an absolute risk reduction in recurrence at 1 year of about 12%, and overall 38% reduced, increased recurrence-free interval. However, I think we all know from our practice that delivering this intrathecal chemotherapy within 6 hours, which is seen as ideal, is often difficult. There's a recent paper from St Mary's Hospital in London which found as few as 28% of patients were actually receiving the post-operative mitomycin C within the given time frame. They found barriers included lack of the mitomycin, lack of trained staff, organisational problems, and also contraindications, including heavy hematuria or concern about bladder perforation. So coming on to the idea of water, distilled water has been shown to be tumoricidal in vitro and in vivo studies, both with bladder cancer cells and also in colorectal and ovarian cancer due to its hypertonicity. It's also been suggested that a single shot of mitomycin, which is 40 milligrams in 40 mils, may not sufficiently coat the bladder to be completely effective against circulating tumour cells, which is the hypothesis of how it works. Irrigation with an increased volume of fluid over a prolonged period of time, for example, water, may be more effective. Studies looking at water in patients following TURBT are limited, but some of the recurrence-free intervals that have been found in cohort studies are comparable with this one from Greek authors, comparable with recurrences seen with BCG over 1 year. So the aim of this study is to investigate whether irrigation with sterile water following tumour resection decreases the risk of bladder cancer recurrence at 3 months and 1 year, which would be the standard time for cystoscopy as a minimum. The null hypothesis would be that irrigation with sterile water makes no difference to tumour recurrence in addition to standard of care. This would be a prospective randomised control trial for patients undergoing TURBT. The only patients that we would seek to exclude would be those with suspected bladder perforation, who would, for whom this may be a dangerous study to take part in. We would propose randomising patients after consent into 2 groups, those that have standard of care, which would include 1 shot of mitomycin, and those that would have standard of care plus 3 litres of sterile water irrigation immediately post-operatively. We anticipate this would be run through whilst the patient's in recovery. The patient would have cystoscopic surveillance thereafter, which would, as a minimum, for the lowest risk, be 3 months and 1 year. This is a flow diagram. So what we suspect is we'd have patients in the water and saline group, but then due to logistical and other issues, not all patients may receive mitomycin. So you'd end up having 4 subgroups, which might permit further comparison. So our primary outcome would be recurrence-free rate at 1 year, but we'd also be interested in look at recurrence rates at 3 months, the safety profile of water irrigation with occurrence of adverse events. In the control arm, we may also be able to look at compliance with standard practice and whether patients actually receive standard of care, which is mitomycin within 6 hours. And then possible subgroup analysis for patients who do not receive mitomycin in those other groups. We've had initial support from Bart's Health Clinical Trials Unit. We've done back of an e-cigarette packet sample size calculations. We think EAU guidelines suggest recurrence rates at 1 year between 15 and 65%. So if we think 30% recurrence rate at 1 year in the standard of care group, if we're looking for an effect size of, say, 25% relative risk reduction with 80% power, we may need 340 patients per arm. We would need to gain full ethical approval because it's a clinical interventional study. So why would this be a good thing for BAUS to support? Well, achieving these kind of patients over sizes over a short period of time means it should be done in several different centres, and a collaborative approach would support this. BAUS is establishing an infrastructure and support for ethical application, statistical support, and data management, so that would all help with that. We don't think this is a controversial study. It's something, when I asked one of my more senior consultants, he said they used to do it in the old days, irrigate with water for tumoricidal effect after TURBT. So this may have been something that's done before and therefore is not going to ruffle any feathers. And for those trainees involved, we hope it will improve their experience of research and also their CVs. So sterile water is pretty cheap compared to mitomycin. Mitomycin is about £79 just for the drug, and then the equipment to give the mitomycin, training, specialist nurse support, drug disposal are all extra costs. The water is, we don't think it's a particularly risky substance. And 3 litres we think will give a decent time and exposure to the hypotonic solution in the bladder. This is Max's email address for contact. Thank you.
Thanks, Ben. Maybe we can start with Graham.
Okay. How many centres do you think you're going to need? I suppose that ties up with how long you're going to run it for. So,
I mean, with these, I think with these trainee projects, it's important that they don't take too long to run. So it may be that we collect data over a year and follow patients up for a year. If we're looking at recruiting about 700 patients, we see, where I work at the moment, we probably see 4 new bladder tumours a week, which would be 200 a year. So it may be that we need a handful. I mean, if with attrition, 10 centres.
So you think you're going to recruit, how many out of that 4 a week do you think you could recruit?
3? 2?
Is this being filmed? I was going to, you probably haven't thought about this yet, but when and how will the randomisation take place? How quickly can you get the water together? Does it need to be done in advance, or will it be when people are on the table?
That's a good point, actually. I think we'd anticipated patients would be randomised preoperatively. Getting the water together, it's equipment which it can be delivered through normal irrigation tubing, which is part of the post-operative care anyway, and sterile water is available in operating theatres readily at hand. So I think the randomisation could be done fairly close to the time of surgery without disrupting the normal run of things.
And have you got any secondary outcomes planned to collect?
So I think the recurrence rate would be the primary outcome, but thinking about what else the data might be useful for, I mean, it would be important to look at the safety profile and occurrence of adverse events. I mean, hopefully there won't be many of them, so it may not be very informative in a study this size. And then the control arm, it would be interesting to see in patients receiving standard of care, how many of them actually receive optimum care as we know it at the moment, because it may be that, you know, current practice is not best practice. So I think a control arm would inform about that.
Okay, if I could just ask one question from the audience. So someone from the audience has asked you, Ben, how will you assess the safety profile of sterile water if mitomycin C is being administered at the same time?
Good question. We'd be collecting data closely from both arms, from all patients. I suspect, I mean, looking at this recent paper from St Mary's, where, you know, as few as 28% of patients were actually receiving mitomycin, that's 3/4 of them potentially who don't, who would be in effect a, you know, group without mitomycin. Half of those would then receive water, and in that subgroup we could then see measure the adverse effects. So I suspect there would be many patients who don't receive mitomycin.
One consideration might be if you're doing an intention to treat analysis and 75% of your men aren't getting your patients aren't getting the mitomycin C, your sample size, you might want to inflate that, which might be quite big then.
Yeah.
It's just something to consider. Mark?
So I think this is a lovely study which lends itself very nicely to a multi-centre approach, as you suggested. I mean, the idea, as you say, is not a new one. Even when the MRC study came out to suggest that early post-operative mitomycin had some benefit, most of the urologists, and there'll be some in this room, probably still gave water because they believed that water was doing the job. But it's never been tested head-to-head. And it sounds as though this is probably the way to do it. In terms of convincing people, I mean, the stats, presumably is it a non-inferiority design, or...
I was going to ask a question of the panel myself, actually, at the end. I mean, if we expect to see a benefit, what would the ideal trial design be? If it's non-inferiority, are we looking at much bigger sample size?
It's hard to argue that it's going to be better, isn't it? If it lyses the cells, as you suggest, then it might be equivalent.
Yeah.
And so non-inferiority might be a more sensible approach. It normally inflates your numbers a bit, but you might your bounds around your 30 might be from 20, 25 maybe to 35. So if it fell within there, you would assume that water was equivalent to mitomycin, and then that would be sufficient to change care, because obviously water is presumably going to be better tolerated. You're not going to have those bad side effects that you occasionally get with mitomycin, and it'll be cheaper. But a non-inferiority, but you will probably need to inflate your numbers to get there.
Sorry, I've obviously misread one of your slides. I thought you were doing water and then mitomycin.
Yeah, so it would be water versus standard of care, so it's water plus mitomycin versus just mitomycin.
So it's not water on its own ever, unless they've perforated?
No, correct. Because water may be worse than mitomycin. So should we not compare water to the best alternative, which is the mitomycin? I mean, water plus, should it be, we thought it should be added.
Then it's not.
Then it's not, no, so it'd have to be a superiority.
But you're going to, the differences will be so small
that
I'd argue almost futile to kind of detect these very, very small differences. So it's whether it's ethical to do the former study, to go back and compare water to mitomycin. But you'd have to have pretty strong justification to do that, I think.
I think you'd struggle to recruit. I'm not sure many patients would allow you not to get mitomycin willingly, despite the fact that accidentally they don't get it. I'm not quite convinced by your numbers, because if you're if 38% of people end up with the mitomycin, wouldn't you be better off focusing on how to increase that 38% rather than trying to recruit your 4 people per week? Because actually at that rate, you'll probably need 25 centres over the same period of time rather than just the 10.
Mm. I think that's a good point. If I mean, within a study, it may be that the compliance with mitomycin administration, having the expertise, the equipment to give it, means that you can get improved compliance. So I think one of the criticisms of these trials looking at mitomycin is that they don't reflect clinical practice, which, if you know, can be a criticism of any study, I guess. But it may be that if compliance within a study is higher, that's less of a factor. But I take your point. I think trying to improve practice to best practice probably should be done before looking at how we can change practice.
Can I disagree with my dragon colleagues? So there may be a role here for running a patient focus group to see which design has the greatest preference or utility for the patients. I mean, many patients want to avoid chemotherapy. If you do get an extravasation with mitomycin, it can be completely devastating.
Yeah.
The patients never forgive you, and some don't recover completely ever because of the fibrosis and stuff. So, and if there's sufficient justification to mount a challenge to mitomycin, and given the uptake I suspect that there is, then this would be in keeping with the kind of the whole issue of kind of less medicine, which these are very hard studies to do. So to design a study that allows you to do less in the future, which is kind of championed by BMJ and other groups such as that. But it might be worth a focus group to see if it would be entertained.
Yeah.
I think to get to that stage, you'd probably have to do a safety profile study in the way that a member of the audience suggested. Probably, because I don't, I accept those comments, but I wouldn't accept a minimal treatment without a recorded safety profile. And despite the recent referendum, I don't think anybody in the country is that easy on their decision.
Okay, thank you. Oh, one more question from the audience. Howard?
May I ask a small question about costs? You're probably also aware that guidance has changed slightly such that mitomycin is only really effective for low and intermediate risk tumours. So potentially for a very small low risk tumour, you could get away with resecting mitomycin, no catheter, no irrigation, no overnight stay. And that sometimes might offset your cost of a vial of mitomycin, which I think is about £60 or £70.
Yeah.
So the premise of saving money might be one that you find a little turn to the funders, particularly for a trial that's, I think, will cost many, many hundreds of thousands of pounds.
Yeah, probably.
I think this photo trial costs 3.5 million for over 3 years, 40 centres and about 900 patients as a comparison.
Okay, thank you, Ben. I'm feeling quite thirsty after that talk. If we could have the last speaker, Sophia.
Yeah. So this is an idea which is very much in its infancy. It's more in the idea stage than anything else, and I'll say that right at the beginning. But from my views of trainee research collaboratives, you need something that's simple, affordable, and something that we come across every day, something everyone can buy into, and something that you probably need larger numbers to answer. So one thing that's always struck me is when patients come in with acute retention, be it A&E and urology get involved because that's the service you offer, or whether they're admitted overnight or whatever, the decision as to when we TWOC them seems incredibly variable, depending on what's going on. Now, Retention is something we all see. Sometimes in some trusts it's all managed purely by A&E, they see and discharge. Sometimes they're admitted for various reasons under the urology teams. Some trusts have a service where urology will see them prior to discharge. And there's various criteria why some people admit, some people don't. Equally, the TWOC practice is quite variable between, certainly trusts I've worked in and what other people have told me about. Some people like to TWOC the next day, some people like to send them home TWOC in a week, some people it's the next available TWOC clinic, whenever that may be. In theory, I suppose having catheter in less time is nicer for patients, I'm sure, and possibly reduces the length of time you have a catheter in to get a catheter-associated complication, but the question is whether or not it's more or less successful. There was a systematic review of management of retention, which didn't show any clear relationship between timing and success. It referred to one big study, which the success rates were higher after 3 days. Looking at that study, it's one by Fitzpatrick and all in 2012, which was quite a large prospective cross-sectional study into generally in retention in general. And the median TWOC range was from 3 days to 8 days. They found catheterization more than 3 days had better success rates, but not significantly so, and did have higher complication rates. So my question would be, does the timing of TWOC have an impact on success? With the hypothesis being, the null hypothesis being it doesn't. Mr. Al-Sheikh at Bedford's very kindly agreed to supervise if we do go forward it. I would suggest we do an initial questionnaire study based on what current practice are, because I know the trusts I work in are quite variable. I don't know what the general practice around the country is. We will get a bit bored with surveys, which would be the drawback of this, but I think it is worthwhile doing, and send it out to urology departments. Who manages the retention? Is it A&E? Is it urology? When they TWOC, whether the TWOC's a community or home, and when they admit their patients. Equally, I think at this stage we probably do need to do a really good literature review to look at all the factors influencing TWOC, which may affect outcomes. I would suggest it's a prospective randomised trial where you randomise to time periods for TWOC. Again, this may alter depending on what questionnaire outcomes are, but provisionally the 3 that I've seen most commonly are TWOCing at 24 hours, 3 days and 7 days. And we probably do need an initial pilot study just to assess the feasibility of this. Primary outcome would be TWOC success. Definition of this, again, is quite variable, but I would suggest comfortable avoiding following removal of catheter, just to allow community TWOCs where you don't have post-void bladder scans, etc. included. The addendum being a recurrence within, a time period, I would say is about 72 hours, to allow for the people that have their catheter removed at home and then slowly go into retention, which would count as a failed TWOC. Secondary outcomes we could look at would be catheter-associated complications, so blockages, systemic infections and hospital admissions for this. I think we would need ethical approval, obviously, because we are affecting patient care and clinical decision-making. But cost-wise, follow-up could be telephone, just to avoid unnecessary outpatients. And if we have ethical approval to contact the patients, then that would be covered within that. Funding-wise, we'd need someone for stats basis. I don't know what we'd need above that, apart from perhaps the logistics of sending out a survey, because the TWOC services are already in existence. Patient population, this is me just postulating ideas really. I would suggest it's men over the age of 50 presenting with their first episode of painful acute urinary retention. 50 I picked as a ballpark figure because as you know, the younger men with retention, it tends to be something slightly different going on. Exclusion criteria, that should say age under 50. Pain-less retention when you're worried about neuropathic side effects, I think should be excluded. Residuals, again, that's a bit controversial, but residuals over a litre, perhaps not suitable. If they've got renal failure at time of retention, no one should be TWOCing them, so obviously they should be out. Active urinary tract infections, female patients, again, because that's slightly different. Someone who's immobile and not suitable for a TWOC, especially in clinic basis. And those who've got known urological issues with previous retention, previous bladder outflow obstruction surgery. Variables to include, age would be an interesting factor to look at, residual volume when they went into retention, use of alpha blockers, use of flip flow valves versus leg bags, any pre-existing LUTs, prostate size, possibly urine dipstick results. Analysis, again, would depend on what we do, but I'd suggest something like a chi-squared with multivariable analysis. Potential problems would be capturing all patients. You would need buy-in from ED if that's where the patients are seen, or possibly offering up a urology service to see these patients just so we can consent them and randomise them. You'd also need a buy-in from your TWOC service to allow people to go to these services, or the district nurses, which may be a bit tricky. Patient preference, again, may vary. I'm sure if someone said, do you want your catheter out tomorrow or in a week, most people would say tomorrow. And so they'd need quite adequately counselling, and ethical approval always can cause issues. But I think, in summary, I think it's the kind of idea that we should be looking at for research collaboratives, because it's very common. There's not a real good prospective evidence basis. It's good potential for trainee-led collaborative, but you would need buy-ins from other teams. So.
Thank you, Sophia. Maybe we can start with Mark.
Yeah, so thank you. This is an area of huge interest about 15 years ago, then it kind of went quiet, I think, as the drug companies stopped being interested in acute retention. Bob Javan, did you find he did an RCT of TWOC at 24, 3 days and 7 days?
Did he?
You'll find it. I mean, I don't think it was that well conducted a study, but the longer duration was associated with higher TWOC rates.
Yeah.
And I think from memory, 30, 50, 70 in terms of recovery. So it would be worth looking at that and seeing if it needs repeating. I suspect it does. But maybe with some of the kind of sophistication that we've got now that we didn't have then, in terms of discriminating between spontaneous and precipitated acute retention, and maybe trying to get as much information, because you never know whether just prolonging things allows the constipation to get better, which then allows you to void, or whether you're actually acting on the bladder, on a intrinsic bladder injury itself, which has some recoverability. So trying to get at the etiology, which still, I think, evades us. I mean, two of these presentations have been about emergency care. Emergency care is really hard to do research in, because you're reliant on other people to identify your patients and to do the stuff, which is why it's such a difficult area. And before you embark on it, I just have some really good thoughts about how you would manage that. Because many have failed before for that reason. But otherwise, I think it's hugely valuable. And I suppose the other one that people have entertained as a control would be, taught intermittent self-catheterization, to have as a control or competing arm. And it might be that those are the guys who get voiding on average quicker than anybody else, because they will void spontaneously.
So there's a question from the audience. How would you ensure that local centres have the resources to do TWOCs at the specified times? As we find we can't get anyone into clinic for at least 2 weeks.
Yeah, and I think that is an issue, but part of the reason behind that, I wonder, is if because there's no evidence, like shouting at people saying, if you leave it 7 days, they're all going to run into complications. I think it depends locally on what's available. I've certainly worked in hospitals where the TWOC is done whenever the TWOC nurse would like to do it, because they run the clinic and we have no ability to change that. Whereas where I'm working now, it's quite easy for us to be able to say we'd like the TWOC on XYZ day. So it'd be something that we need to have a good look at, especially on a local level, and see where we can get this running.
So perhaps centres which can do that can take part, and centres which can't.
Yeah, because some logistically just will not have the capacity to do this.
Okay, maybe Graham?
Well, just as those questions were being asked, it occurred to me that a cluster randomised trial might be better to evaluate this, where you randomise clinics to do it. Then there's less of an issue about trying to randomise individual people to 24 hours, 3 days or 7 days, which might be logistically quite hard to do, particularly 24 hours. You need to be doing it immediately. But that was just an observation. My question for you was that you mentioned that you were going to do a feasibility study, and I would then ask you, if I was on a funding board, what would be your metrics for success, implying that your main trial would be feasible?
What do you mean?
Well, you're running a feasibility study. The feasibility of what? I'm assuming it's the...
Getting it up and off the ground.
Yeah. So how would you judge that it's feasible?
Good question. I don't, to be honest, this is so early, I haven't even worked on the logistics of it. But, I mean, I don't know if if on a local basis you could get enough buy-in from A&E to say, actually, yeah, we'll tell you when someone's coming into with retention, it may be that no one can get that done and no one can get the patient numbers that we need. You know, so I think even basics like that, local level, are we able to run this in this department?
Ian?
Thank you. I think it's a very, very nice study. Do you have any thoughts about numbers that you would need to recruit?
No.
No.
Unlike Ben, I can't do back of e-cigarette calculations on all these analyses. But I think, I mean, looking at HES data, there are a lot of people presenting with these kind of things. I think you'd need to have, because there's so many variables, you know, age, are they diabetic, are they, you know, what's their residual, etc., etc. Some given alpha blockers, some not, some flip flow, some not. I think you would need large numbers, but equally, I think it's something that we could easily get large numbers, because I think there would be enough places that would, you know, this would be a feasible study, and it's a common enough presentation.
And in terms of the follow-up, do you think you could be persuaded to expand that follow-up? Because I think the area that Mark was talking about of pharmaceutical interest, I think lots of Alan McNeil's data for the Alpha AUR showed that a significant percentage of people who had allegedly had a successful TWOC did actually develop retention within the next 12 months or so.
Yeah. Yeah.
So I think if you're going to repeat the various things, that might be a worthwhile
I think that'd be really interesting
extension.
arm to it. Yeah.
So that was going to be one of my questions, was how likely is it that somebody gets this again? Could they, because then you'd have to monitor people about randomising them again if they came in as an emergency presentation. That's sometimes quite tricky to keep an eye on.
Yeah.
The biggest risk factor for retention is previous retention, there's no question.
Yes, and it might well be that the timing influences the re-retention rate, which would be a much more cost-effective argument, I guess.
Yeah.
And patients.
And Sophia, so I think one of the most important things that this study could show, perhaps as a secondary outcome, would be quality of life for patients. So, of course, if a patient is TWOC'd earlier and doesn't have to have a catheter for an extra 6 days, that might make a big difference to their quality of life. So quality of life questionnaires, perhaps EQ5Ds at regular intervals, which wouldn't be too hard for them to do, would probably be a worthwhile secondary outcome.
Absolutely. The only issue is, I think, with PROMs is getting the patient engagement with it. Because if the patient's happy, they don't want to answer questionnaires to say they're happy, do they? So it would require buy-in from patients to get that going. But I think it's a very worthwhile thing to look at. And
the other kind of trendy thing would be nosocomial infection. So if you can get the catheter out within 24 hours, can you reduce the risk of bacterial contamination and therefore subsequent antibiotic use and resistance development? So that would be very, if you look at Medscape at the moment, it's all about UTIs and biopsies. So that would be, maybe actually that would get you funding, if that was the justification for it. You know, so that, you know, for NIHR, research for patient benefit type area.
So just one or two other questions from the audience. Most of them have been asked by the Dragons already. One more on logistical questions about managing these patients on a weekend. So if you have a 24-hour TWOC on a Friday or a Saturday, how would you deal with that situation? Would you decide not to randomise them in the first place, or how would you?
Again, I think that depends locally. I mean, district nurses go out at the weekend quite regularly. So if you have a district nurse service that's willing to support that, fine. Equally, there's ambulatory care units. And I know in the last trust I worked in, we'd have people, sometimes the ones who were a bit unsure about that, we'd just bring into ACU and TWOC there. And because they were such easy patients for ACU to deal with, they didn't mind having them there. So, but that obviously is going to add increasing kind of buy-in from the trust you're doing it with, so you'd need to really persuade them it's a worthwhile thing to do. But I think it's feasible to do it at the weekend, but you would need either an ACU facility or a day case ward facility that would be willing to do it, or a good district nurse setup that would be happy to do it.
Okay, do we have any more questions from the audience? Okay, so Mike coming.
Does this need to be an RCT? Centre A. So if Centre A is already doing a 7-day TWOC and Centre B is already doing a 24-hour TWOC, is it not possible to just compare the two hospitals or 2 centres?
Well, I suppose so, but you don't know whether there's demographic differences between those two groups or there's other practice-based differences which are affecting what's going on. So you'd have to have a really good multivariable analysis to say whether or not, but yeah, it could be a cohort study, I suppose, yeah.
Just a quite useful way of avoiding a lot of the paperwork.
Yeah, absolutely, yeah.
And it would also inform your practice towards an RCT as
But
well.
I suppose part of the reason for doing this is because I've never worked in a trust that has a protocol for what they do. It seems to be a bit ad hoc as to they do what they feel like on the day.
Yeah, again, patient involvement. Ultimately, this is probably going to be a trade-off, isn't it? The earlier you take it out, the higher the risk of going back into retention.
But you get your
and therefore, having patients involved at the outset so that you're sharing those trade-offs. And you design the study so that it informs their decision-making. I think in a study such as this would be pretty important.
Definitely.
Okay, thank you very much, Sophia. So that's the last of our presentations. So the next stage, the Dragons are going to convene and mark each of the presentations, and in 5 minutes we will announce the winner, which will be presented by the incoming BAUS president, Kieran O'Flynn. There was one more question from the audience. Where is the stack of cash that the Dragons should have?
Is it in the president's briefcase? Yeah. It's close. That's how I went.
So I've gone, yeah.
We've got a split. So you went 1, 2.
We've come to a decision. And all 3 entries were quite close in the scoring, actually. I'd like to thank all of the 3 people who entered, and I'm sure you found the experience of putting your ideas together very rewarding. And even for those that didn't win, it doesn't mean your idea can't go forward. I'd like to thank the audience for coming and the Dragons for their valuable input too. So this year's winner of Dragons Den is Ben Lamb.